The following podcast is part of a certified educational activity titled Carrying Through in Advanced Metastatic Urothelial Carcinoma, Expert Perspectives on Recent Practice-Changing Data and the Practicalities of Individualizing and Continuing Care with Novel Immunotherapy Maintenance Strategies, featuring Professor Thomas Poles from Bart's Cancer Institute in London, Dr. Petros Grivas from the University of Washington Fred Hutchinson Cancer Research Center in Seattle, and Professor Johan Loriot from the Institut Gustave Roussy in Paris. Access the entire activity and complete the post-test at peerview.com/RVA860. Downloadable slides and practice aids are also available. Hello and welcome to Carrying Through in Advanced Metastatic Urothelial Carcinoma, Expert Perspectives on Recent Practice-Changing Data and the Practicalities of Individualizing and Continuing Care with Novel Immunotherapy Maintenance Strategies. This activity features Professor Thomas Poles from Bart's Cancer Institute in London, Dr. Petros Grivas from the University of Washington Fred Hutchinson Cancer Research Center in Seattle, and Professor Johan Loriot from the Institut Gustave Roussy in Paris.
So over the last few years, we've seen some major shifts on the treatments available to us in urothelial cancer. Before we look at those advances, we're going to review some of the challenges to frontline treatments. This is a super overview in that we managed to get the whole of bladder cancer onto one slide. NIBC, non-muscle invasive bladder cancer, treated a spectrum of different approaches, moving towards BCG, which is the mainstay of high-risk disease, a regular cystoscopy for the vast majority of those patients, muscle-invasive urothelial cancer, which is T2 to T4A, N0, or dare I say it, N1, M0 disease, and those patients treated with neoadjuvant cisplatin-based chemotherapy surgery, and obviously there's a discussion now about adjuvant nivolumab, which is an exciting discussion for the future, I think. There's also a piece around chemoradiation, which is popular in components or aspects of North America and the UK. I think we need to see more data on chemorad, but what data we do have looks really good in my opinion. I think the next piece really is then locally advanced and unresectable disease, which is an area which we don't have enough data on. And I guess that's T4B, again, N1. How do we treat these patients? I think a multidisciplinary approach is the right approach. And then we're off to recurrent metastatic disease. And this is what we're going to talk a lot about today, first line and second line therapy. The challenges with frontline treatment in metastatic disease, I think it's fair to say that, the median survival in advanced disease has remained stubbornly static for a long time. Patients, the median survival is somewhere between 9 months and 15 months, depending on the trial you look at and the treatment of the patient. We've focused very much on first-line platinum-containing regimes. We're seeing responses or stable disease in the majority of patients, but the real challenge has been that as soon as you stop the chemotherapy, the cancer probably starts drifting in the wrong direction, and the median progression-free survival is only 4 or 5 months. And then I think the second issue then is when those patients' cancer progress, it can be pretty devastating. Second line therapy, most patients don't get it. Those patients that do get it, we've been using, well, in the distant past or the sort of distant past, we were using taxanes and vinflunine, and that's now switched to immune checkpoint inhibitors, Pembrolizumab with KEYNOTE-45 with a randomized phase 3 data, atezolizumab widely used also. And I think that this pattern has been in place probably for the last couple of years now. This slide here is pretty striking, but what I do see is a problem in that we have a lot of bladder cancer patients. We've got a high morbidity, but we haven't got that many patients getting first-line therapy, second or even third-line therapy. What's going on there?
Tom, this is a great question. So this data is in collaboration with Dr. Agrawal and Dr. Swami from University of Utah. And what we see there is a significant attrition. A significant proportion of patients do not receive first-line therapy. And as you see, if someone receives first-line therapy, only about 20% get to second-line therapy, and even 6% third-line therapy from the data with Dr. Swami. And this was a little bit older data, around 2018, just showing how difficult it is to keep patients in line, keep patients in the train of treatment because of clinical deterioration, decline of health, performance status, and access to care. So I think this data definitely support the idea and the concept of how we can sustain, how can we maintain benefit in the frontline treatment so we can maximize the outcome, the best outcomes for the patients. And we see this data across the board in all of those publications. Only a small proportion get to second and third line treatment.
Johan, in Paris, I guess the story is similar. I think in my practice, the majority of patients get second line therapy, but maybe that's not true. Maybe we just forget about those patients that progress quickly and don't do well.
We don't have such data here in Paris, but my feeling is that 50–60% of the patients receive second line, but as you said, some patients progress very quickly on chemotherapy, are not fit enough to receive second line. So I'm not surprised by this data, although we don't have the data here in France or maybe in Europe.
Petros, those patients that progress quickly on chemotherapy, we're going to talk about some data in a minute. Those patients that progress quickly on chemotherapy, who are those patients? And is there any treatment better than chemotherapy for these individuals?
Tom, I think in my personal experience, about 20% of patients, about 1 out of 5 patients have progression in upfront platinum-based chemotherapy. So if you flip that number, about 80%, 4 out of 5, have either response to stable disease. And those patients, are those who have very aggressive clinical behavior and usually do not respond to many other therapies. So in my experience, those patients usually do not respond that well to immunotherapy either. I think there is some overlap in the patient population who responds to chemotherapy and immunotherapy. So I think it's very hard to salvage those patients. Obviously, I think if you go to community sites versus academic sites, you may see a difference. And in my practice, I would say, there is a selection factor who comes to see me in Seattle, but in the community practice, you may see patients with a little bit more poor protoplasm. Now with, novel agents like antibody drug conjugates, target therapies, we may be able to salvage some of the patients, but traditionally it has been very hard to treat those.
So I think that this is a summary slide showing the degree of the problem. Strikingly, less than 50% of the patients getting first-line therapy. That seems much lower than I'd like. I guess we probably treat, I don't know, maybe 75, but it is a challenging disease. And I think starting first-line therapy is really important. One of the things I say, we'll talk about a little bit, is getting first-line therapy right is really important, because I agree that only 17% of patients getting second-line therapy. So when we select first-line therapy, it's important we get the right treatment. There's also a lot of inequality regarding access to therapies across Europe and access to clinical trials. One of the things which is apparent, I think, is that urothelial cancer tends not to be treated by urothelial cancer doctors, but by GU cancer doctors. And that it's part of, often a small part of someone's busy day-to-day practice. What influence, Johan, do you think that's had on the way we treat our patients?
I do agree. I think many patients are treated actually in community center. So meaning that maybe it's oncology that do lung cancer, bladder cancer, maybe kidney cancer. So I think the message we try to release is that if the patient has a bladder cancer, he should be referred to an expert center to select the right treatment at very early when the patient is diagnosed metastasis. But because, as you said, I think the most important way we have to treat the patient is to select the most powerful first line treatment. So it's very important message.
So I guess one of the questions we're going to ask, and Petros is going to drive on this, is how we reach updated guidelines and how we can implement them. And so over to you, Petros.
Thank you so much, Tom, and great discussion with you and Johan, always enjoyable. So I will start by saying that we always, as you mentioned, try to improve upon the outcomes of patients with advanced urothelial cancer. And as you pointed out, we have good response rates with GEM-CIS, maybe about 55, maybe 60% in some series. And with CarboGem, the response rates now approach 40 to 45% in modern data. The challenge is the durability, how long these responses last. And that's why the concept of a maintenance therapy has emerged over the years. And I know both of us have been involved in that arena. The mechanism, in my mind is, how can we think about the effects of chemotherapy and how could those effects, interact with the immunotherapy effects, the effects of immune checkpoint inhibitors. So there is now emerging data, especially with cisplatin by Dr. Galsky and other colleagues, that in addition to direct cytotoxic effects, chemotherapy, platinum-based chemotherapy, can have potential immunogenic effects. And in this slide, you see the potential of immunogenic cell death that could be very relevant in our design of clinical trials. For example, if you have immunogenic cell death from platinum-based chemotherapy, can you follow this with immunotherapy, immune checkpoint inhibition, to capitalize on that and try to increase the ability of the immune system to recognize cancer-related antigens and stimulate an immune response? And this slide, I think, has a summary of different trials trying to improve upon the outcomes of patients in first-line setting. And on the left side, you see the maintenance trials, and we'll talk about the JAVELIN Bladder 100 in a second, as well. And I won't make sure the colleagues know there is also another trial by Dr. Galsky and colleagues presented at ASCO a couple of years ago from the Hoosier Cancer Research Network with switch maintenance Pembro versus placebo that showed the progression-free survival benefit was significant, but there was no overall survival benefit in that study, about 107 patients. In the middle column, you see attempts to combine chemotherapy and immunotherapy, and those trials like Immunotherapy 361, in Vigor 130 were presented, and also the ongoing Checkmate 901. I just want to also point out their attempts to combine different agents. For example, the right column, you see the DANUBE trial that Professor Pauls presented recently that combined durvalumab, tremelimumab, a double immunotherapy combination compared to chemotherapy. That was also a trial that did not meet the primary endpoints. And also we have ongoing efforts like the Checkmate 901 with Ipi/Nivo versus chemotherapy, and the EV302 with a very exciting combo Pembrolizumab plus enfortumab vedotin versus chemotherapy. So as we just discussed a minute ago, the Vigor 130 trial trying to answer two different questions. The first one was platinum-based chemotherapy plus concurrent atezolizumab versus platinum-based chemotherapy and placebo, and with the investigator-assessed progression-free survival and overall survival as endpoints. And the second question was atezolizumab versus chemotherapy, atezolizumab monotherapy versus chemotherapy. And you see here the Kaplan-Meier curves that Tom alluded to. You see on the left side the PFS. There is a modest progression-free survival benefit with a concurrent addition of atezo to platinum-based chemotherapy. But I would argue personally this is not clinically significant, hazard ratio 0.82. And the Kaplan-Meier curves are very close to each other. The median PFS difference was about 2 months. And as I mentioned before, the time of data cut, what Dr. Grande presented at ESMO 2019, there was no significant overall survival benefit at that time. And still, about 2 years later, we have not seen any significant overall survival benefit with longer follow-up. Similarly, in the Keynote 361 study, we actually had a similar question, pembrolizumab plus chemotherapy versus chemotherapy alone, or pembrolizumab versus chemotherapy. And again, in that trial, showed no significant difference in either PFS or OS. You see there's no significant difference. There's no significant benefit by the concurrent combination of chemo-pembro versus chemotherapy alone. And this is the data that, Tom, you presented, and pretty much what I said before. We have the combination of durva-tremi in intent to treat population in all comers, regardless of PD-L1, compared to chemo that did not reach significance, and also durvalumab alone by itself in a select population based on PD-L1 high expression versus chemo, and durvalumab was not able to beat chemotherapy, even the PD-L1 selected patients. And even in the previous Keynote 361 trial, Pembro alone did not beat chemotherapy in PD-L1 high, CPS 10 or higher. We have to see also what the Checkmate 901 shows. And to remind the audience, this is a phase 3 trial, the frontline setting with Ipi/Nivo versus chemotherapy with his GemCis or GemCarbo. And we're going to see the data in different subsets of patients, including PD-L1 high, to see what happens there. But definitely there was a trend, to Tom's point, but did not reach significance. So far, what we have shown you in brief, 3 important trials in Vigor 130 Keynote 361 and DANUBE, all those 3 trials did not change practice. So again, the concurrent approach of chemo-IO we discussed before did not pan out so far. There's the Checkmate 901 also has a GEM-CIS-NIVO versus GEM-CIS, still ongoing, but so far, concurrent combination of chemo-IO does not work that much for overall survival. What about sequencing approach? And what about this maintenance concept to try to keep more patients in the train of treatment without clinical deterioration and ensure access to care? So as I mentioned briefly before, there have been 2 trials, the phase 2 Hoosier Cancer Research Network with Dr. Galsky showing the data about a couple of years ago. We have Pembrolizumab versus placebo with a crossover design. I want to point out that only about half of patients, about 50% or so, crossed over from placebo to Pembrolizumab upon progression, just showing you how difficult it is to salvage patients, right? In the context of a crossover design, a phase 2 trial, only half of the patients crossed over to Pembrolizumab from placebo. And on the right side, you see the phase 3 JAVELIN Bladder 100 trial that Professor Pauls presented at the ASCO plenary session of 2020, and I will show you the data here in a second. Tom, do you want to briefly comment on the idea of maintenance? I know you and me have tried even before with targeted agents. Any quick comment on the concept of maintenance in urothelial cancer?
I mean, the first investigator-initiated trial I did in urothelial cancer was a randomized phase 3 or phase 2/3 maintenance trial. The reason why I think I've always felt it's an attractive principle is it's clear that chemotherapy is good at getting initial control of the cancer, but as time goes by, almost all the cancers become resistant to that chemotherapy. And so, but we also know that if bladder cancer, you let it grow, you let it grow and it causes problems really fast. So that control is really important. If you can get in control of the cancer with chemotherapy, why not then give the immune therapy? Because it's the best of both worlds. Chemotherapy, great initial control, but doesn't maintain it. Immune therapy, not great initial controls, but can maintain the control with chemotherapy.
Thank you, Tom. Great. I'm here showing you the data from the switch maintenance Pembrolizumab trial. Again, PFS, significant benefit with Pembro versus placebo in the switch maintenance concept. These are patients who have response or stable disease to first-line platinum-based chemotherapy. They got up to 8 cycles. And then on the right side, you see overall survival. There was no significant difference between the 2 arms. Again, the crossover was about 50%, and the trial sample size was 107 patients. And that brings us to the JAVELIN Bladder 100 trial. This was a randomized phase 3 study, patients with locally advanced unresectable or metastatic urothelial cancer, regardless of the primary tumor origin. After response to stable disease to platinum-based chemotherapy, they got randomized to either Avelumab and the PD-L1 and 10 mg/kg given every 2 weeks, plus best supportive care or best supportive care alone, with a treatment-free interval between 4 and 10 weeks between completion of chemotherapy and initiation of the randomized treatment in the trial. Primary endpoint was overall survival in the overall population intended to treat, but also in the subset of patients with PD-L1 high tumors. Patients were stratified based on the best response to first-line chemotherapy and site of metastasis. And as you see here in the slide, there was a significant overall survival benefit with Avelumab plus best supportive care versus best supportive care alone. As you see, the hazard ratio is 0.69 with a very significant p-value and clear separation of the curves early on, from the 4th month or so. And the median overall survival difference is more than 7 months, showing significant benefit with the anti-PD-L1 Avelumab as switch maintenance therapy. And this is overall population, regardless of the PD-L1 expression. And as you see, about 2/3 of the patients are alive at 18 months, which I think is very exciting. As we know, the historical data with the disease are very, very poor. So seeing these numbers is very, very exciting. I think it's changing somewhat the natural history of disease. And this is the subset of patients with PD-L1 positive tumors. As you see here, this is an even lower hazard ratio, 0.56, very significant p-value, high degree of separation of the curves. And about 70% of the patients are alive at 18 months. I would say, very, very high degree of benefit and exciting to see this data. And overall, as you see, and as you have heard, on June 30, 2020, the FDA approved Avelumab as switch maintenance therapy in patients who have achieved disease control, meaning response to stable disease to platinum-based chemotherapy. And this has level 1 evidence, and this is adopted by NCCN guidelines, ESMO guidelines. It is now approved in multiple countries. It was also approved in the European Union by EMA and multiple other countries across the world. So I think the practice has changed dramatically. It's really exciting to see these improved outcomes, in those patients across the board. And obviously I want to see how the data evolve in the future with longer follow-up. Very exciting. Tom, I will turn this back to you now.
I've got 3 cases here. They've got different characteristics. And we're going to just talk a little bit about, these patients that should be offered chemotherapy. And clearly on the left-hand side, it's reasonable to say, Jason, a young man, good renal function, PD-L1 positive, but it's not so relevant because they're eligible for cisplatin-based therapy. And they do really well with therapy, 6 cycles given. Maria, slightly, not really, about the same age, but the performance status is 2. I think performance status is so important in this disease. Those patients that aren't in great form at the start, they get fatigued, in my opinion. And then Ellen on the right-hand side there, interesting that she's a cisplatin eligible patient, but only managed 3 cycles because of adverse events, fatigue, and neutropenic sepsis. Johan Petros, how often do you switch across? Would you have switched Ellen across to give her Gem-Carbo? What sort of dose reductions are you making with neutropenic sepsis? Let's make the assumption that she was doing okay on cycle 1 and then grade 2 fatigue on cycle 3, and with an admission for a week with neutropenic sepsis with a neutrophil count of 0.1. How would you approach Ellen?
Probably for this patient, I will switch to Carbogem with maybe dose reductions upfront for Carbo, just to avoid the neutropenia. But I think it's very important that we can try to give this patient 4, 5, or even 6, but at least 4 cycles, just before we know that this patient has achieved partial response, and she should be offered Avelumab then. So I will switch to Carbo to this patient. Yeah.
That's a great discussion. I think the first thing I would do is if the patient can still get through chemo, I would probably dose reduce at gemcitabine in this case. This probably might drive the bone marrow suppression. Carbo is a little bit more myelosuppressive than cisplatin, and I may drop the gemcitabine dose first and then see if I can get another cycle with hydration and best supportive care, and try to get the patient to a 4th cycle, to your point, and then I can see if I can give more or not, and individualize the decision based on benefit and risk, if I give 4, 5, or 6 cycles based on toxicity and response status.
Johan, it's over to you really to talk a little bit about some of the JAVELIN 100 data and some of the subset analysis.
Yeah, sure. Thank you, Tom. So yeah, there are a lot of relevant post-hoc analysis for daily practice actually that were performed in JAVELIN Bladder 100 trial. So I think the first important question is whether or not PD-L1 expression may impact the benefit from Avelumab. So important enough that there was no significant difference between patients with high versus low PD-L1 expression. All patients benefit from Avelumab regardless of PD-L1 expression. It looks like that patients with high PD-L1 expression benefit even more from Avelumab, but I have to remind that interaction test was not significant. So meaning we don't need to look for PD-L1 expression before using Avelumab. So maybe in terms of biomarkers, so it's a complex story. So do you think that it's impossible to get today a good biomarker for immunotherapy, including Avelumab? So what do you think?
I think my take on it at the moment, Johan, is that the PD-L1 biomarker has been really inconsistent. We have many different ways of measuring PD-L1. It's a protein stain with, I think, a lot of variability. I think the TC staining and the IC staining, tumor cell, immune cell staining, have different significance. I think we were a bit naive about that to start with. As it currently stands, whenever we've done a trial and had PD-L1 as the primary endpoint, DANUBE 361, 211, 010, whichever one you want, it's always failed. And so my feeling actually is we need to move on from this biomarker. We've had 4 or 5 big randomized negative trials for monotherapy. Now, it might be for combination therapy, it might be different. For neoadjuvant therapy, it might be different. But as it currently stands, we're really battling with this and we need to move on.
I would agree with that, Tom. And I think PD-L1 has been a suboptimal biomarker, in this disease and has a limited role, and we have to think further and beyond.
Another question, the role of the site of metastasis. So we know from other studies like, there were 45 or bigger, there were 11 that, 211, sorry, that patients with visceral metastasis, and especially those with liver mets, benefit less from immunotherapy. And in JAVELIN, again, the interaction test was negative, indicated that Avelumab should be offered regardless of the site of metastasis, if the patient, of course, achieve at least stable disease after chemotherapy. So overall, the slide here showed that there is no clear subgroup of patients that did not benefit from the maintenance strategy. So if now we go into details, there is a good question of the type of chemotherapy. Is Avelumab less effective if the patient had been treated first with carbo versus cisplatin? So actually not. You can see here that in terms of overall survival on top of PFS at bottom, the patient treated with frontline cisplat or carboplatin combined with Gemza all benefit from maintenance Avelumab. So hazard ratio are very similar and no significantly different. Next question, should we give Avelumab as maintenance if the patient achieve very good response? So PR or even complete response. So sometimes patients are fed up with chemotherapy due to cumulative toxicity, fatigue, neuropathy, or because they want a break actually. So if there is no lesion of CT scan, should we give Avelumab? That's the question. So the post-hoc analysis here indicates actually that there is no good reason to avoid Avelumab in this patient. The patient benefit from Avelumab regardless of the quality of the response. Look at the PFS curve at the bottom. Hazard ratio are similar across the 3 subgroups. Regarding overall survival on the top, no clear difference again. Interaction test was negative. So Tom Petros, it is something that the patient wants after chemotherapy, just to have a long break and not started Avelumab because they achieve complete response, in your experience?
Johan, is a good question. Patients definitely, are eager to get off treatment, especially after chemotherapy and, some toxicity they have accumulated. Overall, that's their mindset. But I have a dialogue with the patient up front at the time of the decision making in the frontline setting. And I discuss with them that if we achieve response or stable disease, then the plan would be to do switch maintenance Avelumab, of course, if there's no contraindication. And the patient has this in their mind. So we try to start as soon as we can, usually a month after the completion of chemotherapy, in patients with either CR or PR or stable disease. And I want to just make a quick point that the CR subset is probably underpowered there with low number of events, but the benefit is across the board, is notable across the board. And I use it for CR, PR, or stable disease.
I don't have much to add. What I would say is that the majority of patients who are getting into trouble with cycle 4, 5, and 6 of chemotherapy, I think that's a really important issue because, if you're pushing the patients through toxic treatment, they're causing lots of side effects. Then, of course, switching to a new therapy, many people say, listen, I need a break. I think it's quite important that and the benefits of cycle 4, 5, and 6 of chemotherapy, well, I think most of the benefit, honestly, is in the first 3 cycles. So I think it's reasonable to look at those 3 cycles and dose reduce, dose delay, omit some of the regimes. We talked about that in some of the previous cases that we're going to come back to in a minute. What I would like to do is have my patient in as good a place as possible at the completion of chemotherapy. And also, I don't want really long delays in that chemotherapy. So as soon as you've got more than a 2 or a 3 week delay, if it's cycle 6 and it's a 3 week delay, you might as well stop, in my opinion. I think that's an environment where you said, listen, let's switch across to immune therapy a bit early.
Thank you, Tom, for this very good transition. So the question is, does the number of cycles impact the benefits of Avelumab? So please remind that the patient were allowed to be enrolled if they had been treated with 4, 5, or 6 cycles of chemotherapy. But is there any difference between 4 or 6? So the response is no, clearly. So we infer the number of cycles of chemotherapy received by each patient enrolled in JAVELIN. And you can see here there is no difference between 4 and 6. Actually, few patients receive only 5, so this subgroup is probably not informative. So the conclusion is, among patients who stop first-line chemotherapy prior to 6 cycles, so meaning 4 or 5, Avelumab maintenance still provides a novel survival benefit. So coming back to your question, Tom, are you aware of any trial that maybe investigate a lower number of cycles?
Yeah, because I think we're doing a study, and I'll talk about that in a second. I think what this data shows, it doesn't say it's safe to give shorter periods of chemotherapy, because at the moment 6 is the standard of care. But for those who can't tolerate chemotherapy, switching to maintenance of Avelumab is the right thing to do. We've got a trial in Europe, and Johan, you and I are doing this with Enrique Grande, and the 3 of us, I'm really excited to work with friends in investigator-initiated trials. It's going to be super cool, I think, because we're doing 3 cycles versus 6 cycles, followed by maintenance of Avelumab. Quality of life is the primary endpoint. But, you know, it's conceivable that by shortening the chemotherapy, the immune therapy may work even better. So I think it's going to be a really exciting study, and it's going to be a European thing. We're going to do it together.
Petros, any thoughts?
I think you have a great discussion. I personally try to get to 3 cycles, and then I do a restaging scan, and then see what the response and the benefit is, and then I balance this with toxicity. And if the patient can tolerate treatment, I will try to go up to 6 cycles, which is a standard, as Tom said. But if the patient is struggling despite some dose adjustment, dose reductions, and doesn't get too much benefit, have stable disease but significant toxicity, I can stop at 4 cycles and then, you know, go to maintenance Avelumab, and the data support that approach. So it's an individualized benefit risk ratio. As Tom said, we don't have much data with less than 4 cycles, but if a patient has substantial toxicity and cannot get through, you know, beyond 3, sometimes you can extrapolate, and switch there. But the JAVELIN had 4, 5, or 6 cycles, so it's individualized. And I'm interested to see what your trial in Europe saw.
This question, should we start Avelumab right away after the last cycle of chemotherapy, or is there any possibility to give a break to the patient? So in the trial, Avelumab had to be started 4 to 10 weeks after the last cycle of chemotherapy. So let's see if there is any impact of the treatment-free interval. So you can see here that hazard ratio is quite similar, around 0.7 in the 3 different groups. So early, intermediate, and late start of Avelumab. So the treatment-free interval does not impact on the activity of Avelumab. So here a couple of additional analyses. So we have to be very careful because the groups are not well balanced, of course. So what we can say is that there is no signal to exclude a subset of patients for Avelumab based on the primitive locations of the tumor, so upper tract versus lower tract, or the site of metastasis. Another complex question arises with regard to the biomarkers. So as you know, a lot of biomarkers are being assessed to predict response to immunotherapy in oncology. So what has been done first was to look at the TCGA classification. So you know that we try to classify MIBC, and there are many different classifications. So here, if we use TCGA subtype, it looks like there is no clear trend indicated that a subgroup does not benefit. Maybe a luminal subtype, but again, the numbers of samples in this category is so small that it is not significant, actually. Tom, Petros, any maybe promising biomarker in the field, in your thought?
We've seen data that innate and adaptive immunity are both required. Active macrophages, so M1 rather than M2. We've seen some data on dendritic cells, which I think are exciting too. I think that there are other pieces which are moving forward. I quite like the circulating tumor DNA data. I think that as a surrogate marker for minimal residual disease, but also monitoring progress is relevant. The problem with TCGA analysis is it's a classification that was originally designed based on the RNA signatures across all of cancer, not just the immune signatures. And so they've clustered cancers together, but there are various different components of the immune signatures within those. And so it's always going to be very difficult to use these to define treatment for immune therapy.
I agree with Tom. I think there is so much excitement in the field about biomarkers, and we do a great job with discovery, but to prove clinical utility of a biomarker is a very high bar. And in different trials, we may measure a little bit different things and different biomarkers with different assays, which makes the clinical utility challenging. I would say I'm very excited about the things that Tom mentioned. You know, we have a very good program in the JAVELIN Bladder 100 trial, and there will be a manuscript will be published very soon. It's actually accepted and will come up very soon, looking at different biomarkers tested in JAVELIN Bladder 100, which I think raises great hypothesis for the future. I think things like TMB and PD-L1 are, are interesting, but not probably adequate. CD8 T cell density is relevant. We looked at also at Fc gamma receptor polymorphism, DNA repair gene mutations. I think overall the message is we are not ready yet to select patients for Avelumab based on any biomarker. I would just, offer it to any patient with responder stable disease. But I think the future hopefully will, more dissection of the mechanism and circulating tumor DNA that Tom mentioned, hopefully will have, biomarker design trials.
I agree. Thank you. Moving now to the safety. There is no new signal actually. Safety profile is very consistent with what has been previously reported with Avelumab or other immunotherapy, with fatigue, pruritus, GI toxicity is the most frequent adverse event. So adverse event led to discontinuation of Avelumab in 12% of the patients. There was some deaths that was attributed by the investigator to the study treatment, so Avelumab in 2 patients, but very, very, very rare. So important enough when a therapy is given for a long time, like Avelumab, it's important to see if there is any impact of quality of life. And here, Avelumab first line maintenance, so improve our survival with no impact on the quality of life. So it's very important to check, and it's very important to know that there is no big impact on quality of life. But of course, sometimes patients stop Avelumab due to immune toxicity. So what are the guidelines? Usually, if toxicity mild or moderate, we can withhold immunotherapy and use corticosteroid if needed, and we can rechange the treatment then. If the toxicity is serious, we have to discontinue immunotherapy, maybe envision hospitalization and high-dose corticosteroid. So Tom and Petros, so do you set up any multidisciplinary approach to manage the toxicity in your center, and how you can provide some tips for the audience, for example?
Sure, I can go quickly and then Tom can comment too. In our center, University of Washington and Seattle Cancer Care Alliance, we have actually set up a tumor board and multidisciplinary tumor board, and we actually invite not only oncologists, but other specialists, right? GI, pulmonary, rheumatologists, cardiologists, etc., depending on what the case is. And that actually has created a lot of enthusiasm. We have actually one later today, and we present interesting cases. So this tumor board is very relevant and educational. We also have developed an email listserv where you have a case that you want input right away. You can email, and there are representatives from each specialty, medical specialty across the board, and they can provide input real time and get the patient very quickly to see a specialist. So this email listserv has helped us a lot. And then there are dedicated clinics. For example, our rheumatology colleagues have set up a dedicated IRA clinic, and they see the patient right away with a very short time until notification and see the patient in clinic. So it's a multidisciplinary approach that has helped us a lot. And we still learn as a team how to diagnose early, educate the patients, and optimally manage IRAs.
So I think that the key is to have a group of individuals with skin in the game who have a desire to work together for these patients. But ultimately, most cancer centers particularly with urothelial cancer, it's a relatively small number of patients. Of course, bringing endocrinologists for complex endocrine toxicity, gastroenterologists in for persistent diarrhea, and in fact hepatitis. Some of the hepatologists at our center are really interested in that. it's a great question, actually, about how we develop this, because it has to be a balance between the clinical team who are in front of the patients looking after them and the background team, the wider team investigating and getting it right.
As part of this educational activity, additional information regarding the management of this toxicity are offered here, and you can download this guidelines for you, your staff, and your patient, of course. So maybe we can go back to the clinical case, and maybe Tom, you can take over.
That's sweet of you. What are we doing? Are we giving this patient, he's tolerated treatment well, let's say he's 4 weeks out, he's come in for his CT scan post-chemotherapy. It's terrific news. CR is terrific news. But you know what? It's not like a CR in other cancers. It's not like a CR in kidney cancer with immune therapy. The median progression-free survival of these patients is only between 4 and 6 months. And the majority of patients, the vast majority, progress subsequent to that. So, you know, most patients who get CR, I think, are expecting more than a 4-month PFS. How do we approach these patients? And perhaps Petros, you'd like to start.
Absolutely, Tom. I think the challenge we have is, as you correctly said, we don't have a reliable biomarker to tell us who is going to progress and how quickly. And I think invariably, there is a very high risk of progression. I think the durable CRs are a very, very low chance. It's a very small proportion. And traditionally, conventionally, we have seen probably about 10% of patients, maybe with lymph node only disease, having a durable CR. So my worry is that this CR in the vast majority of patients is not long lasting. So I definitely give these patients Avelumab switch maintenance. And the other point I want to make is if we look at the CR subset, the PFS was significant in favor of Avelumab, and the hazard ratio for overall survival was 0.81, despite it was an underpowered subset analysis, and there was no treatment by subgroup interaction there. So I definitely would give this patient CR because I'm worried about undertreating, because I cannot predict the future reliably. So I will definitely give Avelumab in that case.
Let's move to the second case, and this is Maria, who's slightly older. Her performance status was 2 when we started, and she was given Gem-Carbo. She had a partial response, but only had 4 cycles of treatment. She was fatigued, and it uses the word frail, and hesitant to continue, and asked for multiple treatment breaks on chemotherapy. This is one of those cases we talked about previously. And I guess my opinion is that those patients progressing with 5 and number 6 cycles of chemotherapy is often counterproductive. Johan, what's your take on this lady, and what do you do next?
I think probably I will try to switch to Avelumab because it's clear that the patient is fed up with chemotherapy. She wants a break, so we have 10 weeks to set up the Avelumab. So maybe we can offer a small break for this patient, a short break to this patient, but we should convince this patient that Avelumab improve probably the control of his disease or her disease. So I will try to convince this patient to be treated with Avelumab. I think it's a good candidate, actually.
Let's move to the third and final case. So Ellen's more complicated because she did really not that well with chemotherapy. Neutropenic sepsis, fatigue, grade 3, which is stopping treatment completely. Was cisplatin eligible, actually quite young as well. What would your approach be, Petros?
So the question here is, can we go more with chemo in that case? This patient has a partial response. She had significant toxicity, got admitted in the hospital with neutropenic sepsis. It's a discussion with the patient. I would probably try to dose reduce gemcitabine at least by 20% and maybe give a growth factor support to try to get this patient through at least another cycle of chemo, if possible. And then I will see how well she tolerated. And then I will make a decision about 4, 5, or 6 cycles, repeat scans if there is response to stable disease. At that point, I would switch to Avelumab maintenance. If the patient completely refuses more chemo, sometimes this happens despite discussion and canceling. We can extrapolate and give Avelumab now, but the JAVELIN Bladder 100 had between 4 and 6 cycles of chemotherapy.
Yeah, we wouldn't be able to do that in the UK because you'd have to give the 4 cycles of treatment as per the label. Johan, what would your take be on giving that fourth cycle? Would it be single agent carbo? Would it be day 1, day 8? Would you just give single agent gemcitabine? Obviously, it was neutropenic sepsis that scared us. You know, if we reduce the doses of the drug, we could probably prevent that happening again if we were careful, particularly with the gemcitabine. What would your take be?
Probably I will remove the day 8 Gemzar and maybe day 1 or so, but keep of course a platinum based chemotherapy, so either cisplat or carbo, but probably I will remove the day, at least day 8 and probably day 1 of the Gemzar.
So I think I'd do the same. I would then see how she gets on with day 1, day 8 carbo. And then if she does really well on the first one and doesn't have too many problems, you know, reintroducing gem at 50%, would that something you'd be interested in? Or if you've given that fourth cycle, all you're trying to do is you're trying to get her across the line to get maintenance of Avelumab, or if she does well on cycle 4, would you go to cycle 6 with suboptimal chemotherapy?
So is this patient, it seems that this patient is quite frail because after 3 cycles, there is a lot of toxicity, grade 2 fatigue, grade 3 neutropenic sepsis. So probably I would just stop at 4, not giving 6, and again, switching very early to Avelumab, I guess. Yeah.
What do we do? Where do we land now with these different approaches? I'm just going to give a quick overview of my opinion. I'm going to start on the right-hand side, if I may. I think second line in pembrolizumab or atezolizumab, and I see them as interchangeable, is associated with good outcomes, but for not enough patients. And therefore, the first line approach is more attractive. And I think it's reasonable to say overall that this maintenance approach seems to be preferable to the other approaches. We talked about some biomarker work for the future, and you know, it's quite complicated in some ways. Here we've looked at the tumor and immune component biomarkers associated with the JAVELIN 100 data, and you can see the TC tumor cell expression hazard ratio 0.35 versus 0.61 for IC. Perhaps tumor cells is more predictive, perhaps perhaps immune cell more predictive, tumor cell more prognostic. And on the right-hand side, you can see gene signatures, and as I said previously, dendritic cell macrophage, natural killer cells, adaptive, but also important innate immunity associated with response to therapy. There are other trials on the horizon, ongoing maintenance trials, cabo plus Avelumab. We've got a PARP inhibitor plus Avelumab. Johan, I think that's a study out of France. We've got Patriot 2, which I think is an exciting multi-center study with first-line Avelumab. And of course, we've got the DISCUS study, which Johan and I talked about previously. So questions from the community for everyone, really. And let's start with the top one, and perhaps Petros, you'd like to do that.
Tom, I think, you know, there are many barriers if we think about across the globe. You know, access to care is probably one of them. And, you know, I'm thinking not only in the US, but I know in other countries. So I think access to care and healthcare delivery is very important. Make sure these medications that prolong life, like Avelumab, can be accessible in patients across the globe. And of course, elimination of healthcare disparities. And this, even within the US, there are disparities in terms of geographical distributions. Patients who live like in, you know, far away, distant rural areas may have a long travel, you know, to come to the cancer center. So we try to, you know, address that, you know, by providing some support in those patients if we can. The other thing is toxicity from chemotherapy, and the patients want a break that Johan mentioned before. And that's what takes a discussion with the patient. And as I mentioned, my take is we have the 4 to 10 treatment interval. I err on the side to start treatment earlier than later to avoid progression, but I think this depends on the discussion with the patient. The third thing, you know, we think about, you know, the complexity of care these days, you know, infusion rooms in cancer centers get full. So we need to have more space, right, for our patients who live longer, which is a good thing that they live longer, and we want them to live longer. So have to have enough capacity, and obviously the cost of the healthcare system overall, you know, in terms of, you know, treatment of patients, you know, management of IRAEs that we discussed before. But I think at the end of the day, having patients living longer and better with good quality of life, you know, is very, very important.
Johan, any differences between Europe and the United States in terms of what you've just heard from Petros?
I think the problem of reimbursement is not a big problem in many countries in Europe. So in the vast majority of in Europe, the Avelumab is reimbursed. I think the most important point maybe is the awareness of oncologists in the community practice, I would say, because there is some oncologists doing lung cancer, GU cancer, GI cancer. So we should maybe try to find a way where these oncologists are aware that Avelumab is approved and the patient need to be treated with Avelumab as maintenance. So it's a matter of education, meeting, and interaction between expert center and all the oncologists in daily practice.
Let's just talk about the final point on this. How long can you use maintenance regimes? Johan, how long would you give it for? Is it until progression? Is it a maximum of 2 years? Have you got an algorithm in your mind?
It's a big question. So we don't know exactly. So usually I go to 2 years, and after 2 years, we have a discussion with the patient. So just to remind that in JAVELIN trial, the patients were treated until progression or withdrawal or safety, toxicity, sorry. So that's a discussion case by case again, and there is some clinical trial in different countries in Europe and probably in US where the duration of immunotherapy is addressed, not only in bladder cancer, but in oncology in general. So maybe we will have some response and some tips to address this question, which is still difficult at this time.
Johan, from a patient's perspective, let's start at the top as well, and perhaps Petros, you could kick off on this question as well. Why do we need both from a patient's perspective? I mean, maybe I'll take that one. I mean, I guess that it comes back to that principle of get initial control with chemotherapy, which is hard with immune therapy, maintain that control with immune therapy, which we can't with chemotherapy. Can I have a break between chemotherapy and immune therapy? I think it's reasonable. Johan showed those slides. Yes, you can. It's up to 10 weeks. I think if you get the chemotherapy right and there's not too much toxicity, my preference would be to be somewhere between 4 and 6 weeks. Remember, bladder cancer progresses quickly, and it's important that if you've got that control with chemotherapy, to not let it slip and the cancer progress, in my opinion. And why can't I keep going with chemotherapy if it's working? And which one of you two wants to take that question?
I think it's toxicity, mainly toxicity, right? That, neuropathy, fatigue, bone marrow suppression, and other accumulated toxicity. I think, the more cycles you may hit wall at some point. So I think I usually stop at 6 cycles if the patient can tolerate well.
Sorry, maintenance lapatinib trial, the original study we did, we showed a 30% progression rate between cycle 3 and cycle 6 of chemotherapy. Many of those patients were having delays, chemotherapy, and weren't getting the treatment in on time. And we had a podcast, we did a Euromigos podcast with Dean Bajoran in our sort of Legend series. And I asked Dean the same of how came up with how him and his colleagues came up with the number 6. And the answer was that they started by just continuing. And if you do continue chemotherapy, in the end, the cancer grows through it. And so I think that was a really interesting piece from Dean about how we got to where we are today. Remember, in lung cancer, they give 4 cycles, not 6. And actually, they chose 6 to some extent as a compromise on what was going on in other tumor types. So we've got some take-home points here. First-line platinum-based chemotherapy, I think, is the preferred option for patients with metastatic urothelial cancer. I think we're unified on that. And this switch maintenance strategy enables more patients to receive immune therapy as part of first-line therapy, rather than waiting till second line, which I'm afraid is too late for most patients. I think the overall survival and progression-free survival benefits speak for themselves. The hazard ratio of 0.69 is the lowest that we've seen. And I think that this is an important continuality to try and bridge this gap in the efficacy of clinical trials and real-world data. We haven't seen that much real-world JAVELIN data yet, which I think is going to come in the not too distant future. Johan, Petros, thanks a lot. Anything you'd like to say before we call it a day?
So thank you. I think it's a very important activity that we did today, because I think we need also to give some update on the changing landscape, and obviously Avelumab changed the landscape in first line. So thank you for this activity.
I agree with that, and I will just add that it's so difficult, as you know, Tom and Johan, to change practice across tumor types and have a phase 3 trial showing overall survival benefit and with no detriment in quality of life. So I think it's great to see this data improving outcomes, longer life, longer progression-free survival, and a trend towards actually less clinical deterioration or delayed clinical deterioration. So hopefully we'll have even more outcome improvements in the future. Thank you so much for inviting me.
And to thank our audience, and also to remind them that they can download the practice aids associated with this educational activity. Thanks again. We hope you enjoyed it, and see you soon, I hope.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RVA860. This activity is supported by an educational grant from Pfizer and EMD Serono. This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.